All right, so let's talk about immune disorders. So, before we get into it, so we've already talked about quite a few immune disorders in MedSurg overall. Like, who could name a couple of the immune disorders we've already talked about? MS. D maybe. We could even go back to rheumatoid arthritis. There's a lot of different disorders that have immune components. So today, when we're talking about the immune system, you guys aren't going to come away knowing all of the disorders that happen with the immune system. But some of the things that I want you guys to think about some common immune issues. And there's some common types of immune disorders. And then kind of from there, it will inform you of how to care for most of those immune system disorders, right? You can kind of take some generals and apply them to most of them to help you in the future. So when we talk about disorders, there's three categories. There's the hypersensitivity reactions, there's autoimmune disorders, and then there's immune deficiencies. And we're going to cover all of these today as we kind of talk together. So first, hypersensitivity reactions, right? So we're going to talk a little bit about kind of what these mean. It might be anaphylaxis. There might be some transfusion, like blood transfusion reactions, transplant rejection. When we talk about autoimmune disorders, excuse me, these are some common examples: rheumatoid arthritis, ulcerative colitis, multiple sclerosis. You see that these are all different body systems, even, right? Because the immune system, depending on where it's kind of attacking or triggering, it can impact any system of our body. And then immune deficiencies, some examples might be like AIDS, like we talked about last week, right? So those are the couple examples of immune deficiencies overall. So hypersensitivity reactions, and you guys did a good job in your homework, your reviews this week of saying like, hey, it has to do with what type of tissue is injured. And we classify them as 1, 2, 3, and 4. I'm probably not going to get into a lot of that as far as testing is and like knowledge base. I don't think that's so important that, is this a 1 or a 2? What I want you to know is more of like, what's going on in the patient? What is the priority intervention? What do we need to do about it? And then how do we treat that? If that makes sense. So anaphylactic reaction. Usually the reaction occurs immediately, right? Because sometimes we'll talk in a little bit, there might be some delayed reaction where you're introduced to something, but it might be hours to days before you have that reaction that happens. With anaphylactic reaction, those are immediate. You're exposed to the substance and you have an immediate reaction. It can be mild, but it could be severe and life-threatening. And with anaphylactic reactions, did they usually get better or worse over time? Worse, right? Because as your body's exposed, it's building up more and more immunity to whatever that trigger is. Your book had lots of little pictures. I'm not going to go into them, but if pictures help you understand the different types of reactions and what's happening, I encourage you to go in and look at these pictures because it really does kind of say like, hey, look, here, you're exposed, and then you build these little Y things are antibodies. And from there, those antibodies, then they attach to the mast cell. So then when you're exposed again, those antibodies are what pick up that little piece and then just have fun. Because what's released from the mast cells? Histamine, yeah. That makes me think of the drug classification that we give often. Antihistamines, right? What's a common antihistamine? Diphenhydramine, Benadryl, maybe cetirizine. There's all kinds of antihistamines because we're trying to block all of the histamines that are getting produced when those mast cells release. Okay, so allergic rhinitis, that's probably one of the most common forms of allergy. You see me up here all the time, like touching my nose, itching, sometimes I'm sneezing. I got some pretty good allergic rhinitis. And so when we talk about, like we've talked about rhinitis, when we talked about upper respiratory, right? Because we remember that rhine, for word building, what is rhine, that first part of the word? Nose, right? And itis? Inflammation, usually inflammation. So rhinitis, it's an inflammation of the nose. And usually you guys have all seen it, right? You're itchy, stuffy, sneezy. It's not that you have a cold. There's not an infectious process, but it's that there's an inflammatory process. Sometimes you can hear this called hay fever if it's seasonally, or somebody might just say I have seasonal allergies. And that's usually if there's something that's growing that's produced that you're really allergic to. Anybody know what ragweed is? In the Midwest, there's this weed called ragweed, and it makes my life miserable. I just start, when it starts blooming, when it's growing, and it has this pollen and dust that's produced, I just start sneezing and coughing, and I mean, I need lots and lots of antihistamines in my life to be able to function, because that really affects me. So you might not have this allergic reaction all the time. It might be just to certain things, or you might be like me, where I kind of always have a little bit of allergic rhinitis. And if I'm exposed to something different, things like ragweed, it might make it worse. Another thing, right? Atopic dermatitis. You guys did a good job again in your homework at identifying this is eczema, right? And eczema can range so much in how it affects patients because it depends on how much the immune system is really reacting, right? Some people might have very mild forms of eczema. Some people might have some pretty major forms of eczema. Have you guys seen all of the medication commercials on TV with eczema? I feel like the immune, like medications for immune disorders, they are getting so much publicity right now with all these commercials. Like, I feel like you can't watch a show on TV or a streaming service without seeing like these commercials for different immune medications. So with eczema, pruritus, what is pruritus? Or pruritus, right? The itching, right? You're really itchy. They can get swollen, really dry skin. They can have blisters, crusty, scaly skin. Sometimes it's kind of patchy. It just depends on where it's at. And again, the extent of it is how bad this person's reaction is. So you're caring for a patient with atopic dermatitis, which is eczema, whose arms and legs itch and they cause discomfort. What are some things we can do, some actions as nursing that we can take? So turn to your peers, talk about just a couple things. What can you do as a nurse to help this patient? All right, let's compare our answers to F.A. Davis. So, have they been prescribed medication and are they taking it, right? That's important to know because if it's so bad, they are coming to a provider. Let's make sure we're following our plan. Then we often will say lukewarm soaps. We don't want like the soap to be too hot or cold. Oftentimes they'll say, put things in your soap like oatmeal or things that are soothing to your skin to help, excuse me, with the irritation. And then you might have some sort of cream that you put on top, especially in areas that are more affected, just to help with moisturizing the skin, calming it down. We really don't want them like itching at it or scrubbing or doing anything that's going to irritate it anymore. We talked about that. Okay, so let's say you're observing a patient who's receiving an antibiotic. Which of these do we recognize as a sign of anaphylaxis? Should be able to select all that apply. So let's talk about what we have here. So stridor, what is stridor? It's kind of like wheezing, but it's in your upper airway it usually is indicative of like edema around your epiglottal opening. Anybody know what it sounds like? It's like right, because it's like bad singing almost, because the noise is that it's swollen. Like, right, we make noises sending air in and out, but if it's tight, we're not going to be able to breathe as easily. We're going to be making some funny noise. Wheezing, right, in our lungs, we might hear wheezing. That's different than stridor. Respiratory arrest might happen too. Because of that blockage, they might not be able to breathe, right? Like it can get swollen so much, it might cause blockage where they can't breathe. Hypertension and bradycardia really aren't signs of anaphylaxis. So severe type 1 sensitivity reaction, it's widespread with this histamine release. You get like those little Y things that we saw, right? They are attached to those mast cells, and then when you're exposed to it again, you just, those mast cells go and they release so much histamine. You usually have hypotension, tachycardia, and eventual cardiac arrest. Yeah. So one thing, so which do we, actually, I'm going to go back for a minute. So I want to tell you guys a story, right? We all love story time. And since my son Preston is our long-standing case study, he like has had every issue. He's kind of my kid that's tested all of my nursing knowledge. We have long history of nut allergies in my family. My husband is allergic to tree nuts, which is different than peanuts, right? Just PSA for everybody, so we know there are peanuts, and there's a lot of people who have peanut allergies. Peanuts are different than tree nuts. Peanuts are actually a legume, like a bean, and that's the family that they live in. If you're allergic to peanuts, you're more likely to have other legume allergies. Tree nuts are like cashews kind of, but anyway, pecans, walnuts, all of those type of like the nuts, if that makes sense. So they call them tree nuts because they grow on trees. So my family, not my family, actually, my husband's family has long history of tree nut allergies. My husband is allergic to tree nuts. Now he's never had a severe anaphylactic reaction, but he's had some minor reactions before. And so we just don't have nuts in our house. When my son was around 8, I was making brownies that came in this mix. I think, is it like turtle brownies that have pecans on them? Maybe there was some mix, but it had nuts in the mix. And that's what I had picked up on accident. And so I was baking it for this thing we were going to. And, telling my husband, yeah, leave these alone, don't eat them. But for my son, he was like, I want to try one. And so he ate one and he goes, oh, my tongue kind of feels itchy. And I was like, ooh, okay. What do you think I gave him right away? Benadryl. And it was after hours. So the next morning I called his pediatrician and I said, I think he might have a nut allergy. I have a concern, right? I cussed him out. I'm concerned. We have history of nut allergies. He had this happen to him. He said, oh, okay. So I'm so thankful. He ordered an EpiPen, sent that to the pharmacy for me, and then did a consult so we could go see an allergy doctor to kind of do some more testing. A couple weeks later, we had friends stay with us and they ended up giving us these chocolates. So after they left, we're eating these lovely chocolates and they're from Belgium, these friends of ours. And so I wasn't really looking at the packaging so much because I couldn't read Dutch. And then as we're eating them, my son goes, my tongue is, Mom, something was in there. And he had just taken like the tiniest bite and he spit it out even. He didn't even like eat all of it. He just had chewed on it a little bit. After a couple minutes, I was like, oh, so I went and got him some Benadryl. He took that. He started to just be like, he's like, my chest is feeling tight. I don't feel good. Then he started going outside and just spitting. And I was like, why are you spitting? He's like, it doesn't feel like I can swallow. And I was like, okay, this is time. So even though I'd given him Benadryl, that was not enough. I could tell, because what's happening if he can't swallow? What's happening inside? Getting swollen, right? I started noticing there were even like hives around his mouth. So I was like, okay, buddy, we've talked to you about EpiPen. It's either you're going to do it or I'm going to do it, but it's time. And so I can still picture him in my head. He sat on our couch and he gave himself his EpiPen, right? And EpiPens, I meant to bring our trainer sets, but did you guys practice those or look at them in lab? maybe. I'll bring them next time I come in. They have some training ones, but I mean, you usually go with the outward, kind of like if you do an IM injection of the thigh, you kind of go in the outward part of the thigh, right in the middle. Usually it's right where, if you kind of put your hand down, and he gave himself the epi. After a couple of minutes, I'm looking at him and he's okay. He's not getting worse, but I pick up the epi and I look at it, and inside there's still liquid that I can see. And I was like, did it not work? I mean, he looks okay. He doesn't look great, but I'm like, okay, well, epi always usually comes in a 2-pack because you might need 2 doses. So I said, well, we got to do the second one because I don't know what's going to go on. I don't know if there was medicine left over in this, what it is. So we gave the second one. What I found out later, just so you guys all know, in case I've been trying to teach people about this, is that epi or epinephrine, EpiPens, they come with a full milligram, a liquid of a milligram dose. But what you actually is injected is, well, for his age it was 0.3. And that's the adult range too. So you have 0.7 that's still left in there. I don't know why they do it like that. It's not like you can use it again. That medicine just gets thrown away. So it's very bizarre to me that it's not loaded like with just what you need. But just so you know, if you ever have to give an EpiPen or look, there is extra medicine in there that's not given and it's on purpose. It's okay. So after you give epi, what's the first thing you need to do if you're in a home environment? Well, if we're talking about somebody who's not usually, this is like, let's give education for somebody who's non-nursing, and even for me who was nursing, you call 911, right? Because we give the medication, we treat, we want them, but if we have parents or people who have allergies, we want them to treat right away and then immediately call 911. Because even if that epi worked, we still want them assessed by some healthcare providers. And here's the thing, especially with an ingestion, or if somebody got a bee sting and something has been injected into them, something like that, epi has a pretty short half-life, right? You guys remember half-lives from pharmacology, how long it's going to work in your system? The length of time those things that can be in your system that are irritating you can be very long, especially ingestion, right? It's going through your GI tract. It's going to take a while to exit. So that epi is going to wear off a long time before that whatever that you're exposed to has exited your system. So we called 911. I'm so fortunate to live close by to some of my friends. And I texted my friend, I said, I need help. And so she came over. And so it was kind of comical because in emergency type situations, and you guys might find that you do this already, or you might just do it once you've been nursing for a while, I get very calm. So we were just sitting there on my couch in my front room, and my son sitting there, and my friend sitting over across here, and my daughter sitting here with her little book things because I said, go pack what you need because you're going to be going home with my friend for a little bit. And the EMS, the fire truck comes, ambulance comes, and, they come in ready for an emergency. And we're just sitting there. And I just kind of did a little, kind of like an S-bar. And I said, here's what happened. We've done 2 things of epi, and by this time he looked great. His heart rate was a little bit up, right? Why does your heart rate go up? Right? The epi, right? And so he goes, well, he looks okay now. I said, yeah, he does. And so then he looked at me, he goes, well, what do you want to do? And I said, well, that wasn't a question I was expecting. I said, I think he needs to go to the emergency room. He goes, okay, do you want to take him? And I was like, I don't think I should. He goes, and I think because we were just so calm and we just presented as so like not a big deal. He goes and he like kind of rolls his eyes at me and he got on the phone and he walked outside and he goes, I'm gonna call Mary Bridge. And then it was kind of funny because within like 15 seconds, he like, okay, guys, get him loaded up. We got to go in right away. And it was, because it truly is an emergency with what had happened with him. And please, I'm not trying to speak ill of our paramedics, our first responders. I think it was just because we were just so calm, and my son did look so much better. And I think this guy was maybe newer or something. It just was kind of funny to me that I was like, I am not getting what I thought I was going to get. So we got our first ambulance trip to the hospital. The doc looked at him, and even after those 2 doses of epi, he said his epiglottis was still really swollen, probably one of the more swollen ones that he had seen after having epi. So we got to go home that day. I'm so thankful. What do you think they prescribed for him to go home? Some medication to keep taking. We got steroids, and then we had more antihistamines because as that medication, but as that, even though it was a tiny, tiny little bit of chocolate he was exposed to that had, it was hazelnuts. That's what was in it. It was hazelnut. And so we had to take that for, I think it was 5 days, because they wanted to make sure he was covered as that moved through his immune or his digestive system, that as his immune system kept reacting, there'd be medication to kind of counteract that. So now we're really careful because we know now, looking back, when he had those brownies, that was his initial exposure, right? We had been so careful not to have nuts because of my husband's history, that was his initial exposure when he built those little, those Y, little antigen things, right? And then they just lived in his system waiting. And then when he had that second exposure to that chocolate, his whole system went wild. So now we carry epi with us because it's super important. Usually, I say that. He's supposed, the poor kid, right? Because he's supposed to carry epi with him. And then because he's a type 1 diabetic or just a diabetic in general, what else should he probably carry with him? He carries insulin all the time, but I'm thinking emergency medication for diabetes. Glucagon, right? I mean, this kid's probably going to be like a walking pharmacy if he ever complies with taking everything he's supposed to. He doesn't, so I'm just praying hard over that kid. Let's go this next question. Oh, did I just give you all the answers? I probably did, but let's go ahead and answer them anyway. So which of these would the nurse anticipate being ordered for a patient who's experiencing anaphylaxis? All right, let's check. So yeah, oxygen, right? We might want to help supplement if they're constricted and they're not getting a lot of air in, we're going to make it real dense with oxygen. They might need some epinephrine, right? We're probably going to be giving that. Unless you're my son Preston, who's a diabetic, you're not going to be giving insulin along with it. It's not indicated for anaphylaxis. We're going to give antihistamines, corticosteroids, and a lot of you missed the ventilation, but that's something we want to have in our back pocket. We're not going to come right away and say we need to intubate them, we need to have ventilation, but we know if we cannot, if they're not able to breathe on their own, we might need to put in a tube, like to kind of protect their airway so that swelling doesn't compress it too much. So which of these interventions do we implement for a type 1 hypersensitivity reaction? All right, so yeah, monitor respiratory status, monitor their level of consciousness. Why do we monitor level of consciousness? If you know what to do, respiratory status, right? Because if I'm not ventilating enough, if I'm not perfusing my brain, probably going to be getting a little wonky in my brain. They don't need isolation. We do want to give them information, right? We want to say, hey, this is what's happening to you. Then we want to make sure we give them a lot of teaching to know, like, here's how to help prevent this from happening again, or what to do if you're exposed. And then the itchy skin, that's more of like eczema that we're talking about. So anaphylaxis, immediate, we want to make sure we've got oxygen, epi, antihistamines, corticosteroids. If it gets severe, they might need vasopressors or mechanical ventilations. The biggest thing we want us to be able to do is recognize this early. Nursing, when we say nursing care, this is not only for us as like medical care providers. It's also for the home, right? Like making sure that people know, hey, if you've had a reaction to something, let's make sure you know what to look out for to know when it's severe, when to give medication. Um, let's say you're taking care of some patients. What are the situations that you're going to be really careful and monitoring for anaphylaxis? You're mumbling. Sure. I always think of first dose antibiotics. If somebody's never received that type of antibiotic, they're getting a lot of times getting an IV medication, IV antibiotics. If it's their first dose, I really want to look out for that. I want to make sure there's no, because there's a lot of sensitivity with antibiotics. I also think about patients who are getting contrast dye, right? Some sort of Graham study, because there's a big crossover with what kind of reaction with contrast dye. What'd you say? So people who have allergies to contrast dye often have allergies to something else. Something they eat, seafood. Yeah, seafood, right? Seafood. But talking about eggs, a lot of vaccines, right? When we're giving vaccines, there's some vaccines where you have to wait in the room for a certain amount of time because they want to make sure that you're not going to have a reaction to that vaccine. So there's certain times when we as nurses, we're not going to always be on a high alert, like for every single thing anaphylaxis, because that would just wear you out and it's not realistic, right? If you assess every patient you give Colace to make sure they don't have anaphylaxis from it, you're going to be exhausted and you're going to waste a lot of time. But if you remember, there's some situations where there's higher incidences of having a patient have anaphylaxis and being aware of that. That's going to help you identify those patients if they're having issues early on. All right. Urticaria. I feel like that's such a weird word. Hives. But you might see urticaria sometimes in medical charts or when they're prescribing things. You know, usually if a provider will prescribe something for urticaria, they'll also say or hives, but sometimes they forget. It's from that release of histamine. And you can get these raised little areas on your skin that are very itchy. They're not usually tender, like they're not painful, but they're just itchy. And usually, you know, if it's severe, right? Widespread hives, there's other issues happening, you might need epinephrine. A lot of times, antihistamines will be enough to control that. Angioedema. That is swelling in the tissue of your kind of face, mouth, concerning because that's how we breathe, right? There's some medications and things that have higher incidence of it. ACE inhibitors is one. I remember my sister-in-law took a job up in Alaska. We used to work as travel nurses together, long time ago. And then she continued her schooling and became a nurse practitioner. And then she discovered this program that would pay back her student loans if she would go work in an area that was very underserved, didn't have a lot of medical providers. So she went up and worked for 5 years on this little island in Alaska that had 700 people and 4 providers and the dentist. It was kind of funny. There were 2 medical doctors and 2 nurse practitioners. And I think there was a lab tech or somebody that helped, but I mean, there was just so much. And so on her first day, she showed up to her office and there was a bear in the parking lot. And she was like, what is this? And then the second day, there's a patient that had a newly been prescribed an ACE inhibitor and came in and was like, something's wrong, hugely swollen. They had to protect their airway and send them off to Juneau, like on a medical helicopter, because he had angioedema from his ACE inhibitor. She called me after those 2 days. She goes, I don't know if this is the place for me because I don't know about this. The rest of her week went a lot easier. But it's a very scary emergency situation. And like, it's good, like she identified, okay, we don't have a hospital here. We have a clinic. So this patient needs to be immediately identified. They gave them epi, they gave this guy steroids, but they also sent them off, right? So if you ever see somebody that you're concerned with this, make sure you know if you're in a clinic or urgent care, you're probably gonna be going, okay, this type of, you're gonna cuss out your provider or your nurse, whoever you're working with, and say, I have a concern. I think this might be a angioedema. You know, this is a safety issue. I want to make sure we identify that. So treatment, right? We tell them to avoid the allergen. Stop taking that ACE inhibitor. That's not good for you. We might give them some medications for prophylaxis to prevent that, kind of depress their immune system from responding. Sometimes you can give them other medications like this plasma-derived medication or fresh frozen plasma itself. Sorry, I'm skipping this one. Sometimes these other medications just can help control the symptoms that they're having. So when we're looking at the type 1 sensitivity, the biggest overarching themes, right, is that monitor their respiratory status. That's going to be our biggest thing, right? When we talk about priority nursing interventions, priority nursing assessments, look for that airway. Look at their level of consciousness, because that's letting you know how well their brain is getting perfused. Stay with them, keep them informed. Look at lesions. If it's like a dermatitis issue, make sure we teach them, hey, don't scratch at that. Don't, sometimes people have home remedies that they learn, their grandma told them, and it's what always worked. Make sure we ask, like, what's in that, right? Because sometimes there's home remedies that can actually be counterproductive. They can be more irritating, actually, than they are helpful. Explain need for medical alert bracelets, right? That's so important. I think somebody identified that on the homework this week with the allergy thing. I thought was such a good point. I don't know if I even commented on that, but just making sure going forward that we're teaching people, if you have an extreme allergy reaction, you should be wearing a medical alert bracelet, right? My non-compliant son should be wearing probably 2 or a dual that says type 1 diabetic and nut allergy. He doesn't wear it. He trusts the Lord more than I do. And then we also want to teach them, like, how do you avoid this, right? What is your thing that you have issue with? Is it latex, right? Well, anytime that you go into a healthcare facility, make sure to say, hey, I have a latex allergy before even people touch you, right? All right, so type 2 hypersensitivity reactions. With this, we're going to talk more about blood donation or blood transfusion reactions. So you all have a type of blood. Anybody know what their blood type is? Oh, yeah. It's going to be O, A, B, or AB, and it's going to be either positive or negative. When we talk about blood typing, I'm not going to get into all of it. Do I have it on here? Okay, good. I pulled this little chart off the internet because I think it's helpful. Can I make this disappear? I can't really make it disappear so much. But you can kind of see the donor. So if you are a donor, and let's say you are O positive, you can donate to AB positive, but not AB negative. Why is that? They're negative. So the positive, that's the RH factor, right? You guys learned about this. We learned about OB, right? Because if a mom, if her RH factor is negative, and during birth, she's giving birth to an RH positive baby, she's then exposed to that. The issue isn't that initial delivery, that initial exposure, but it's that later, the mom is going to build up antigens against that RH factor. And so afterwards, if she's pregnant with an RH positive baby, she's going to miscarry. So that's why it's so important. What is the medication we give mamas who are RH negative? Rogan, right? Because we want to make sure we're protecting them. We don't want to cause them to miscarry. Good job. Kathy would be so proud of you guys. Okay, so going down, O, and actually maybe I should say it. O, if you're type O, it's kind of like this, it's universal. You don't have anything. Sometimes I like to think of it as there's markers on the blood cells. I know this isn't in reality how it works, but like O is just this beautiful blank space. O negative, it's just nothing on it. O positive, it's got this little positive on it. It's got the RH factor that's on it. And then you might have A, right? And it's got the A on it. It's hanging out. And then you might have the A positive. And it kind of continues on where you would have B that might just have B or B positive, or one that has A and B, and one that has A and B and positive. The thing about it is that if you're somebody that doesn't have many of these markers, like if you're somebody who is O positive, you can't donate to somebody who's O negative because that RH factor is going to trigger a response in that person. So as long as you have these markers, you can receive it all, right? If you're AB positive, well, you can receive anything. You can receive, it doesn't matter what the blood type is. And there's a lot more that goes into it. Like there's like subtyping and like compatibilities and all this stuff that they do, but this is just very general. So it's really important that we do this type of matching. Anybody see the show The Pit? Yeah, it had a mass casualty episode that came out recently, and it was interesting because people were just like donating blood and then administering to it, which is very rare, and you're not going to see that. But one thing we want to know is that it's not the first incidence of exposure that's usually going to cause the issue, right? So let's say if you have a mass casualty, a lot of times we'll say we want to give them O negative blood, right? We can't type and screen them right away. We don't know what blood type this patient is, but we know O negative is going to have the least chance of causing a reaction. Sometimes, if we're running low on blood, especially for men or women who are above childbearing ages, we'll say, go ahead and give them O positive, right? Because they might then form that sensitivity to the RH factor, but the chances of them having like a mass casualty where we can't screen them again is pretty low. And it would be just, it's not going to hurt them in the meantime. Does that kind of make sense? I always thought that was kind of interesting in how we allocate blood. Okay, let's see. Did I explain that part? Moving back. Okay, so if you give somebody blood that's not their type, or not their, it's not been screened and typed accordingly, you can have a type 2 hypersensitivity reaction. Here you can kind of see where it again shows you the little pictures of how it kind of can destroy the red blood cells. So I want you guys to, we'll read these and we're going to turn to a partner and discuss this just for a minute. So a person with what blood type is the universal ABO-RH recipient, and which one is the universal donor? And then if you're verifying a unit of packed red blood cells before it's administered, can the patient who is B negative safely receive the O positive blood, and what would you do? All right, so turn to a partner and discuss those questions.
Yes.
All right, let's compare our notes to F.A. Davis. So AB positive is the universal recipient, right? And O negative is the universal donor. And then no, right? Because that patient was RH negative, we can't give somebody was it O positive? What was the Yeah, O positive blood because of that Rh factor. That's gonna cause an issue.
On one of your slides, it says O is the universal donor.
Yes,
So does that, is there an O positive and an O negative?
yes, yeah.
But it just says O is the universal donor.
I don't know what slide we're talking about, but just, I mean, but it's important to know the O, you can donate, but you also, you're looking not only at the blood typing, the ABO, you're also looking at the Rh. So yes, O is the universal donor, but it's O negative can be given to anyone. So I would say O negative is the universal donor. I'll have to look at the slide later, I'm sorry. Okay, I also found this offline too. I thought it's helpful because our book and everything really talked more about hemolytic reactions. But if you guys are involved in blood transfusion, you're monitoring patients after, I want to make sure you guys know there's hemolytic reactions, but there's also allergic and febrile reactions that we see with blood transfusion. And they're a little bit different. So allergic, just like you think about, right? It could be mild, but it could be severe depending on the extent of the allergy. And so really we look at like wheezing, anxiety, their blood pressure might drop. Febrile, it's like what it sounds like, pretty much, right? The temperature goes up. Because that temperature goes up, we're gonna see the heart rate go up, the respirations go up, they might have fever and chills. Totally different types of reactions than the hemolytic reactions. When we go to monitor patients, that's kind of what we're monitoring, and I'll get to that in just a second. So if you have a hemolytic transfusion reaction, right? It's that those red blood cells have something on them. The body's going, whoa, 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 whoa. This is an invader. And they attack it as if it were something negative that was going to cause harm to it. So they lyse, or essentially, they just kind of blow up those red blood cells and have this cascade of allergy that just, or the allergic reaction that happens. The biggest thing is for prevention. I've never been part of a blood transfusion reaction that was because of giving improper typing. I've seen patients that have had febrile reactions and some that have had some allergic reactions, but none that it's been because we gave them the wrong. Some things are really important with that. And a lot of that is the nursing care that goes into before you give the medication or before you give the blood. So in the state of Washington, I kind of did some research this weekend. Some of the legislation seems to, as it's changed a little bit, where it looks to be as far as I can tell, that LPNs can administer blood, meaning that initial events, like the initiation of the transfusion. But it's up to individual hospitals, companies, places to decide if that's what they're going to allow their LPNs to do. I believe last time I checked Good Sam, it's not within an LPN scope of practice for their organization for the LPN to initiate a blood transfusion, but they can monitor after it's been initiated. That kind of makes sense. So it's really important that we understand, kind of like, I like that we're also doing transition class as well, because when we talk about scope of practice, so important that we can know, okay, what is our scope of practice in the state? But also, what's our scope of practice for this company? What did they allow us to do? Because you can sure get fired for doing something that's in your scope of practice in the state if your company says, no, we don't want you to do that. Okay, so if you're allowed to initiate or start a blood transfusion, it always is 2 nurses. Now, depending on the place you work, it might be 2 RNs, it might be an RN and LPN, it might be LPN, but it has to be 2 licensed providers. It can't be, an RN and a CNA, or, like it has to be 2, like either LPN or RN, depending on what your company says. This is Epic, what this looks like. This is not a real chart, just so we all know. Epic has a playground where you can practice. So this is just a playground, pretend chart. But when you go to give a blood transfusion, there's scanning that you do. So you'll do it if you ever get to practice it. But then you have something that comes up like this and it has a unit number. Has anybody ever given blood before? when you give blood directly on that bag, it has a unit number. I used to donate all the time. And I told you guys some of my like anemia issues over the last few years. It's one of my saddest things that I can't donate blood anymore. But I used to always look at my unit numbers because I always was curious, like, will I come across this? Like anytime I give blood in the next 30 days after that, I always be like, what's that unit number? What's that? Maybe is that my blood that that I donated? I'm O positive, so I can donate to lots of people, maybe not the O negatives out there. But each unit of blood is going to have a special unit number. And just so we all know too, when we talk about blood transfusion, usually you don't give packed red blood cells. That's like or not packed, or whole blood, excuse me, whole blood. So when you donate blood, you're donating whole blood. Not everybody needs whole blood. In fact, usually they kind of parse it out. It's kind of like saying you don't need a whole meal, but maybe you need the protein and you need the carbs and you need the vegetables, they kind of say, here's the packed red blood cells, and here's the platelets over here for somebody else. Here's the plasma that somebody else might need. And they kind of separate it all out because blood is kind of a precious commodity. We usually don't have enough of it. And so we don't waste giving whole blood to everybody when we can kind of give people just what they need. So this would be a packet of packed red blood cells. And here, it even says right here, it is A positive. Super important when you're looking at the blood bags, they're gonna have where it says the ABO, this one is A positive and a unit number, and it also will have an expiration date. Those are the big things that when you are double checking blood transfusion, you're looking at the ABO, the RH, you check the unit numbers, and you check the expiration date. And then you check it again when you check the patient. You are very deliberate in how we do these things. Now, you need to make sure that you have vital signs before you start the blood transfusion. Why is that important?
So if they have a reaction.
We want a current baseline. Usually, and you have to follow policy. Every place is different. Usually it's within the last 30 minutes. Sometimes it might be within the last 15, just depends on what your policy is. But you don't want to say, oh, hey, I got their blood pressure this morning at 6 a.m. and now it's noon. I want a new set of vital signs to know where are we at right now so I can compare anything to. This, do I have it? Huh. Well, maybe I put it later. Okay. I also put in some epic documentation pictures, I hope. We'll see if they come up. So therapeutic interventions, if they're having a hemolytic reaction, we might give them some antihistamines, some corticosteroids, and sympathomimetics. If we know, especially with some of our oncology patients, if they, we might, because we're suppressing their immune system, usually with their treatment, if they need a blood transfusion, they often will have some of these febrile reactions. And a lot of times they'll get pre-medicated by their doctor. They'll just say, before you begin, give them some Tylenol, give them some Benadryl. Let's see if we can diminish the symptoms of that reaction because we know they're probably going to have one because of their history. So if we're giving a transfusion, what are we monitoring? Well, just so you guys know, and again, depending on your policy, what your companies will allow, you have to have an RN or an LPN that sits with that patient the first 15 minutes. You do not leave their side. Why is that? Yeah, look for a reaction, because if you're going to have a severe hemolytic reaction, you're going to see it begin right away in that first 15 minutes. Then afterwards, usually it's vital signs every 15 minutes or half hour, depends on your policy, up until when the blood is finished. Anybody know how long you can transfuse blood for? Usually 4 hours max. Sometimes if somebody like has CHF or there's some issues where like if they don't want too much fluid all at once, you might want to like make it a little bit longer. But once you've hit the 4 hour mark, you've got to throw it away. It's considered not safe to give anymore. Kind of like if food goes bad, you leave it out too long. That's kind of the thought. It's more susceptible to developing like growing bacteria or something. We want to infuse normal saline with new tubing every time we set up a blood transfusion. And we'll get to that in a minute. Oh, good. I did put it in here. Okay, so this is the EPIC chart for blood infusion. I don't know if you can see it super well. Are you guys familiar a little bit with Epic from some of your clinical rotations? Hopefully the screen isn't totally new. But this is what the flow sheets look like. This will look depending if you're in Cerner or I haven't seen Point Click Care if they have a blood transfusion like flow sheet, but they all look similar to this. And with blood, first of all, it's gonna have you go through this checklist at the beginning. I really love it because it's like, hey, there's supplies. Are there any suspected symptoms or interventions? Oh, wait, that's the, never mind, we don't do that. Oh, this is after it's transfused. So this one was already given on this one. So here it has oxygen therapy on the flow sheet. Like we say, when we gave here, they gave a new bag of red blood cells. And then it's kind of nice. They have the blood administration supplies. Those tubings, different things, the charges for blood is kind of high. Oftentimes charges are a whole thing, who knows? Anyway, actually, I'm not gonna get into that, it's too much. Let's rewind if I talk about charges. Just know it's nice they have it on here. But then they also have underneath here, they say, hey, what's the oxygen level? Are we giving them anything? What's their respiratory rate? And then this next picture just goes down. Maybe it doesn't go down as much. Oh, I went up above here. It tells you, hey, what are their vital signs? Make sure we're looking on there. Usually they'll have, on the blood flow sheet, we want to look at their vital signs, want to look at their respiratory status. Every once in a while, there'll be some on there that will say, hey, are they having any flank pain? Are they having any itching, any issues on there? Okay, so you're caring for a 50-year-old female who has had a blood transfusion reaction. You noticed the remaining unused blood and blood tubing hanging on the IV pole. So she already had the blood transfusion done, but she had a reaction, and so they stopped it, but the rest of it is still hanging. What do you do with that? So take a minute, talk to your partners next to you. We'll compare. All right, let's compare to F.A. Davis. So first, make sure they're labeled correctly, put it in a biohazard bag, and then you send it back to the blood bank. Because anytime that somebody's had a confirmed or suspected transfusion reaction, you send it back to the blood bank because they're going, hey, was there something wrong, right? Did we mislabel this? Did we mistest this? What happened? It goes back to lab so that they can do an analysis to figure out maybe on their end, why did that patient have a reaction? Okay, let's take a break. We'll get into type 3 hypersensitivity reactions when we come back. So let's go till 11:15. And then we'll come back and we'll finish strong. All right, so type 3 hypersensitivity reactions, that's where you have an initial exposure to something, but then your reaction can happen much later. It's not the same as that anaphylactic or the reaction where you have kind of that immediate reaction. Not going to get into it more than that. Serum sickness is something to know about. Usually it's from anti-venoms, rabies vaccines, some sort of immune type medication. It's trying to, or prevention, it's trying to help you build some immune system. It causes inflammation issues for 7 to 21 days. It usually is not a chronic problem. It's resolved usually once you've kind of formed the antibodies, antigens that you need. And usually the treatments just vary on the symptoms just to make patients more comfortable. So if they're itchy, give them medicine to help with the itching. If it's painful, give them medicine for the pain. Type 4 reactions, they're another delayed reaction. It's a cell-mediated response, can cause necrosis. That's all your book really had on that. I'm not going to go into it a whole lot. Contact dermatitis, that's where, it's super common if you work with allergy and whatnot. And that's just where you have itchy skin. There's irritation to the skin that happens. Sometimes it can be just even from people changing laundry soaps or exposed to other chemicals or irritants in the environment. Often poison oak, ivory, or even latex could be a culprit. Therapeutic interventions, right? Well, we want to give probably antihistamines to help with that allergy reaction, and then give symptom management, things to soak with, having medication that might help. You also want to make sure latex allergy protocols are followed. And I can't remember, again, somebody this week in their homework did a really good job of talking about like with the patient who had the allergy to latex, the catheter, that makes sure that we follow these protocols. If somebody's going to have surgery and has a latex allergy, we're going to make sure all of those surgical instruments, all of the things that we're using are latex free. Most things in the medical field, a lot of it has gone latex free already, but we always want to double check, especially if somebody already has an allergy. So if the nurse is caring for a patient with latex allergy, what interventions should the nurse implement? And it is select all that apply. So yes, make sure they have an ID band that has allergy on it. Make sure we have a latex-free care kit, meaning we just want to make sure everything we're bringing in has no latex in it. Post signs, this person has a latex allergy, and then review your policy and your protocol for your facility that you work in, because it usually will have things in place to help protect your patients. Transplant rejection, that's another type of sensitivity reaction. We know it's a foreign object that's living inside somebody. We give medications and immunosuppressants to usually help prevent this, but sometimes your body will still, even with cross-matching, making sure that, these patients are screened and they're matched accordingly, sometimes they will still sense that and have a reaction to it. Eventually, it could cause damage to that organ and cause where they have to remove that organ, or it could cause widespread damage if it's not caught and treated, and even cause death. One of the big things that is for nursing is education on why we take those anti-rejection medications, why it's so important to continue to take them and not miss doses, because we want to make sure that those patients we want to keep suppressing their immune system, right? As important as our immune system is, if they have a heart, lungs, liver, kidney, whatever the transplanted organ is, they're not usually going to be able to live well without it. Autoimmune disorders, we kind of talked about this already. Your body recognizes its own cells as foreign, and then it attacks those own cells. So it depends on what the body is sensing. Pernicious anemia, that's one of the ones, several of you guys looked at pernicious anemia on your system disorder sheet. But essentially you get this vitamin B12 deficiency. Anybody seen patients who have vitamin B12 on their medication list? Maybe a few nods. I would be curious if you see that, look in their history and physical. My guess is a lot of them have pernicious anemia. It's always nice to kind of be able to correlate that. You can have this be acquired, like maybe it's not an initial piece where if you have your gut is resected, sometimes because of how you're able to absorb B12, or you're not able to absorb it because of a gut resection, it might not be necessarily an antibody, antigen, or an immune response necessarily. But you do have the symptoms of anemia. Idiopathic, autoimmune, hemolytic anemia, very big words. But essentially you have these auto antibodies that attach to your red blood cells and then lyse them or like kind of destroy them. And so you're not destroying all of your red blood cells, but enough of them where you do have anemia, you get fatigue, and all of those signs with, anemia that you might have, or you're pale, weak a little bit. Sometimes they might even have jaundice because their liver is working overtime to clear out those destroyed red blood cells. Monitor for the symptoms, plan rest periods, and also educate them. Hashimoto's thyroiditis. Some of you guys did this for your care, your system disorders. So that's where you have these antibodies that will go, autoantibodies that will destroy your thyroid stimulating hormone. And eventually, your thyroid gets enlarged, and you have hyperthyroidism that develops. And so usually you have to go in and then, or pardon me, then you have these other antibodies that destroy the thyroid cells and cause hypothyroidism. So there's kind of like these phases of it where your thyroid gets enlarged, you have hyperthyroidism, and then it ends up destroying that thyroid tissue. And so you get hypothyroidism. And then treatment, just like anybody with hypothyroidism, is to give them thyroid replacement hormones like thyroxine. What time of day do we usually give thyroxine? Morning. With food, without food? Without food, yeah. Good job, you guys. You guys have grown so much. I was reflecting on that this weekend. In fact, I was bragging about you to somebody. I was like, I'm just so proud of this cohort of students. They've just come so far and they're looking so good. And they're just all like just ready to like launch and be nurses. So I'm very proud of you guys. Okay, lupus. 3 types of lupus. Usually you're going to see systemic lupus or SLE. But it's important to know that's not the only type of lupus. Discoid lupus, erythematosus, hard to say, right? Skin lesions, just affects the skin. You had a question on that, I think, on your homework review. You might have drug-induced lupus, which usually is resolved after certain medication use. But like I said, the systemic lupus is what you're going to see most likely when you have a patient that has lupus. So usually when you have a patient with lupus, the typical patient is going to be young women in their childbearing years. That's just kind of what we often will see. Oftentimes there's a genetic component that they have relatives that have lupus. And then Black, Asian, Hispanic, and American Indian populations have an increased risk of having lupus overall. So signs and symptoms, this butterfly rash, I feel like that's an NCLEX. Like there's always like an NCLEX question that has butterfly rash and it's talking about patients with lupus. Because that's, yeah, exactly. It's kind of this like reddened rash that goes over the skin and it's kind of shaped like if you had a butterfly, it's kind of shaped like a butterfly over the skin. But you can like early symptoms are really vague, right? They're just tired. They might run slight fevers, but they might feel like they have a cold. But then they have these rashes, bruises. They start to get where it's affecting different systems, which is why it's called systemic lupus, right? It's affecting all these systems, excuse me. So musculoskeletal, they're having these like arthritis or arthralgias affecting their hematological system. They might have anemia, thrombocytopenia, cardiopulmonary. They might even develop all these other cardiac issues because it's affecting all of these different systems. Also, oh yeah, renal's a big one. Anytime you have a patient with lupus, we want to make sure we're looking at their renal function to see if it's affected their kidney function, their central nervous system. Sometimes they can have some neuropathies. They can cause seizures. GI, so a lot of times you guys will get pancreatitis. They might not want to eat because it's painful. They might get anorexic. And then they can also have some eye issues as well. So you can see how we say lupus, but it's a system. It affects all these different systems, and it doesn't mean that everybody's going to have the same systems affected, or only 1 or 2 or 3. It kind of can vary with each person and how it affects them personally. Therapeutic interventions, well, symptom management, but we might give them some immune suppressants, try to suppress the immune system from attacking all those different areas. Steroids, maybe some NSAIDs to help with inflammation, and maybe even some immunoglobulin to help with that immune system as well. Complications, I'm not going to go all into this, but just kind of progressing of whatever system it's attacking. You know, if it's attacking your kidneys, well, you might end up with chronic renal failure and end up being on dialysis. So just kind of whatever disease or whatever system it's attacking, it's that system that's going to have the issue. Moving on, alkalizing spondylitis. That's another example of one of these autoimmune conditions. To me, I think about it as like super arthritis. But usually it's like these large joints, the costovertebral and sacroiliac joints specifically. And they just have this pain. You might have some changing in the shape of the spine or the vertebrae itself. And then because it has that autoimmune component, they also have fatigue, weight loss, anorexia that can also be included as some of the symptoms for this. There's no cure. We want to do supportive therapy, help them, you know, especially their posture, you know, if we can get them posture more aligned, help support that, maybe some range of motion to keep them as mobile as possible. Immune deficiencies. I think that's the last area we're talking about today. So this isn't necessarily a disease that's attacking the immune system isn't attacking something. It's where maybe you just don't have enough of part of your immune system to be able to fight off infections. Kind of like AIDS, like we talked about last week, right? That's where your body isn't able to fight off all the infections around it. Hypogammaglobulinemia. Such a hard one, guys. But that's where you're deficient of one or more of these 5 different immunoglobulins. So it just makes you more if you think about anything about if you're like, okay, my immune system isn't working well. Well, what's going to happen? Well, you're going to be more prone to infections, right? Where am I at? And what do we do about it? Well, we prevent, right? If we know you're more prone to infections, let's try to prevent you from getting infections. You might have to have maybe some injections to help with the IgG. Oh Lord, I went too fast, sorry. And then maybe some genetic counseling too, right? Let's see if we can figure out what's going on with this. This is something that your family is going to think about in the future as well. All right, next question. The nurse would evaluate the patient with hypogammaglobulinemia as understanding methods to prevent infection if the patient stated which of these. So are we asking for true or false answers? True answers. So we say, what is true? Select all that apply. I know. Believe it or not, there are some skin conditions where they recommend that you don't shower every day because you can rinse off some of the body's natural oils and things that can kind of strip your body. Seems very odd to say. I don't know about shower weekly, but not showering every day could be an answer for some questions. Okay, so don't attend family gatherings, meaning don't be around a bunch of people that you might be exposed to different viruses, infections, things like that. We want them to make sure they clean their skin breaks, maintain hydrated, right? If you got your water bottles, drink them now. And then make sure they seek medical care promptly because we know if they have immune disorder, they wait longer to seek treatment, their chances of having complications are going to be a lot worse. The end. I'm so glad. I thought it was I was trying to kind of hurry through because I thought we still had a lot more to go. Let's take a break. Not like a real break, but just like a mental break. Before we go into before we go into the group work, I just wanted to go over with you guys the answers to the case study. Because I think it's always nice to see like what are these answers? What should I have done? Especially before we do this next case study. All right, where are we here? Okay. Do I have it on here? Oh. Gonna have to go back and forth. I did not pull it up on here. Okay, so if you want to pull up your case study to see how you match, I gave you credit just for doing it, but sometimes it's always nice to double check, like, how did you do with your answers? Okay, so we have you're an LPN, you're inserting a urinary catheter for a newly admitted patient age 59 with new onset urinary retention of 825 mils after 12 hours and no known drug allergies. During the procedure, he develops facial swelling, urticaria, pruritus, blood pressure of 98/78. The nurse stops the procedure and maintains the patient in the supine position. All right, so what priority data do we collect first? Most of you guys had it, right? Airway and respiratory status. I'm so proud of you guys. You really are doing such a good job of identifying like what is the priority nursing assessment and the priority interventions. Who do we collaborate with? Registered nurse, supervisor, the healthcare provider. Tracy, I think you're the one that said maybe rapid response in your answer, which was so good because depending on where you're at, this is a severe issue. We want to make sure we're notifying people. And just to empower you guys, you're going to be new grads pretty soon, and you're going to be in situations where you're not sure, and it's okay to be unsure or uncomfortable. What's the big key with that? Don't be uncomfortable alone. Don't be nervous alone. I'm going to keep saying this all the rest of the term to try to like pound it into your brains. It's okay to be uncomfortable and it's okay to be nervous, but don't be nervous alone. That's when I've seen students make the biggest mistakes, or even people who aren't students and that have been nurses for a while. It's that something in their gut or inside of them goes, oh, this isn't right, but they don't go seek advice or bounce it, like talk to somebody. So don't be nervous alone. If you have rapid response as part of your hospital thing, if you have a charge nurse or somebody else you can get to right away, yeah, feel free to talk to them. But if you can't get somebody right away and you're concerned about your patient, call a rapid response. There's no extra charge. There's no extra thing for that patient other than making sure that they're safe. So please call the rapid response if you feel like that needs to be done. Kathy, you had a question?
There was another assignment that we were doing that we were just reading about data collection. And so I thought that question was asking, it says what priority data does the LPN collect first? So I thought it was talking about demographic data or the primary medical history, current medications and family history, or has this happened before? Things like that.
I see. I mean, and it's not bad information, but when we talk about data collection, usually, or at least in the school setting, we're talking about assessment a lot of time. And that's part of the assessment, but the priority is respiratory, like airway management. Okay, so then it's progressing. The patient's given epinephrine and diphenhydramine. The LPN continues to monitor him. His airway is patent. The vital signs remain stable. What actions do we take in order to prevent the patient care and relieve the retention? And we are going to use a latex-free care kit and a latex-free urinary catheter, right? Because that's not I think some of you guys struggled with this a little bit going, well, let's try something else maybe. He hasn't been able to pee. And chances are with this allergic reaction, that's probably going to make him tighten up a little bit more. Like, so we're going to need to catheterize him, but we're just going to make sure we use a latex-free catheter. What education do we give upon the patient for discharge? Well, we're going to talk about he's probably going to need to carry epi with him afterwards in case he's exposed again. And talk about what other things might occur with latex allergy. Like you might have increased sensitivity to avocado, bananas, kiwi, tomatoes. There's some crossover with latex sensitivity and those food items. And then the next thing was SBAR. SBAR, we're done with this shift. How do we hand off? So the suggestion was you've got a male patient, 59. We tried to put a catheter in and he had anaphylactic symptoms during the procedure. So we stopped. No known allergies. I would also put in here, well, I would say we suspect now latex allergy. Urinary retention for 12 hours. So assessment, we gave him these medications and now his airway is patent, vital signs are stable. His urinary retention was relieved after we used a latex-free catheter, and we're going to continue monitor for a recurrence of symptoms. And monitor the urinary output, provide and reinforce education prior to discharge. We didn't put it on here, some of you guys did, but just talking about how we're recommending doing like latex-free protocols, some signage, make sure he's got a bracelet on, and that might be stuff that we had done in our or in our shift already. But just making sure it's a safety things that we're making sure we're keeping him safe going forward. All right, so now that we did that case study, we're gonna do another case study. And let's just go on kind of table groupings. I think the bag of equity can stay inside of its little case today. We pass these down. We're gonna read this all together. So I guess group up in no more than 5 students. Yes. Oh, yeah. Okay, so I'm gonna go ahead and read this and you guys can read along with me. So the scenario is we have Ruth Newport, 25-year-old female client, being treated at the clinic. Is this what I did? Oh yeah, I did. Sorry. I took an old case study that I've used before and I like beefed it up. So I was making sure this was the right one. 25-year-old female client who's being treated at the clinic. So you're the one working in the clinic. She's been treating for after a yellow jacket sting on her left forearm. The client had 2 stings from yellow jackets 20 minutes ago while she was working in the yard. She stated that she's never been stung by yellow jackets or other bees before. She stated that immediately red streaks formed at the swollen site of the stings on her left forearm, going up the arm, and she developed swelling in her face and neck, and her lips became swollen. She stated she has no shortness of breath or difficulty breathing. A friend told her to take diphenhydramine or Benadryl immediately, so she took 50 by mouth. She also placed ice locally. Her vital signs are temperature 98, blood pressure 110/60, heart rate 100, respiratory rate 22 breaths per minute. The physician examines a client and ordered for the client to have an EpiPen to take with her. He also sent an electronic prescription to the client's pharmacy so she'd have it readily available in the future. The physician told the LPN she needs to teach the client how to use the EpiPen and how to store it. So you guys as your group, you're gonna do all of these together, and then I'm gonna randomly choose which question I ask you guys. So do them all. So first thing, a little bit of kind of test taking strategy, information gathering. You're gonna highlight the important assessment information. I didn't give you guys a link to the Word document, but just go through and highlight or circle what's the important piece. Before you guys start that, make sure you're collaborating as a group when you do that. Before you begin, let's read through all these questions. So number 2, what type of hypersensitivity reaction are they experiencing, and explain your reasoning. Why did they give Benadryl and what are the limitations? What are the immediate nursing priorities? Explain the rationale and why he ordered an EpiPen, even though she's stable. Explain teaching you should provide about the EpiPen. And then why is it important for her to seek medical care even after using EpiPen? And why should she consider wearing a medical alert bracelet or necklace? And what should include? All right, go ahead and work through those questions and then we'll go over them together as a group.
I love the epic. It's like, was it more to buy